Good morning, everyone. Hope everyone's doing well. Let me know if you can hear me. All right, perfect. Hopefully everyone had a good weekend last weekend, being safe and whatnot. I think this is where we left off last time, but if not, just let me know. Yes, good morning, everyone. We'll get started in just a couple minutes here. Yes, good morning, bright and early. Fortunately, I think everyone's commute was pretty easy. I hope. I just tripped over a few toys on my way into my office. Good morning, Sadie and everyone. We'll get started in just a couple minutes. Just letting everyone roll out of bed and get on YouTube. Just remember, if you have any questions that come up or anything, please feel free to post those up in the chat or on the sticky board. I'll make sure I get any of those addressed when I can. Can anyone confirm this is where we left off last time? With our drug elimination? I believe that was the case. All right, perfect. Thank you, Valerie. Alright, looks like we got about 2/3 of the class here. I'm going to go ahead and start recording. Alright, so thank you for everyone joining me this morning. Hope everyone had a good 4th of July, doing whatever you were doing, socially distant, I hope. I'm going to finish up this section here and then go into Unit 4. And that'll be the end of the testing material for the second test. Remember that second 25-question test to be held next week. And then we'll talk about the assignments as well that are due in 2 weeks. So anyway, without further ado, I get started. Now that's really washing me out. I might try to turn my monitor brightness down here a little bit just so you guys aren't having to look at me like a ghost. That's probably no fun for anyone. A very bright monitor. Alright, hopefully that'll help out just a little bit. But anyway, okay, so we were talking about drug elimination in terms of, we talked about the metabolism, distribution, absorption of drugs, and all of that. Well, how do they get out of the body, right? If you recall, we were using our drug metabolism pathways in order to, in general, get things sort of more water soluble, so that way they're able to be processed through the kidneys. That's going to be one of the main ways we're eliminating stuff out of the body. You're going to find that the biliary tract is also going to be sort of a secondary pathway, depending on the particular drug, and you can kind of see that here. I just remember the drug itself, either through oxidation, which we remember was a pretty major pathway with cytochrome P450, whether it's going through some phase 2 metabolism, something like that. You're going to then find that urinary elimination is really important, and then, as I mentioned, the biliary being a secondary for some drugs. Some drugs actually go through majority elimination through the biliary tract. Just really depends. If you think about things like estrogen-based products, those go almost exclusively through the biliary tract. So what you're going to find is that many drugs are going to be able to be freely filtered through the glomerulus. You may find, though, that once they're filtered, once they're into that nephron, that they can be reabsorbed fairly easily, especially the more lipid-soluble product is there. And we can actually modify this. If you recall, when we talked about things like pH of a solution versus the pKa of a drug, that can actually affect how well things get reabsorbed. If you recall, things that are positively charged, they have a harder time crossing those membranes. Things that are not positively charged or not charged at all, they're going to have, they're going to have an easier time getting across. Charged things, harder time crossing. Uncharged things have an easier time. So the urine pH, you can see, can range pretty greatly depending on the situation, because this is a major way the body helps to regulate its pH is by the elimination of things like, bicarbonate through the urine there. And it can range just typically on the more acidic side, like, say in the 4.5 to, maybe 5 to 6 range, but it can go all the way up to a pH of 8 depending on the situation there. And so what you tend to find is that when you have more alkaline urine, you can actually do things like excreting, weak acid drugs even faster. Actually, I do this for patients who have an aspirin overdose. One of the ways I try to get rid of it out of the kidneys faster is actually by giving the patient sodium bicarb, right? Bicarb's a base that alkalizes the urine, increases the pH. And if you recall, we said that like dissolves like, so putting a weak acid like aspirin into a basic solution makes it so a lot of it's really highly charged. And so because of that, it can't get reabsorbed from the kidneys so well, and then it gets eliminated faster into the urine, which is good. But you may actually find in some other cases, though, that you can have trapping of items as well. So you can have drugs that once they partition across a membrane, they can actually get stuck there depending on the pH. And so we'll see this more when we talk about like pregnancy and lactation, because you can find that drugs will get partitioned to the breast milk or the aqueous humor, or different things like that based off of the change in pH once it crosses that barrier and into that other fluid, right? Because we know that the blood, is roughly between 7.35 and 4.5, but if then the drug partitions into the urine where the pH is 5, you can find that can shift that ionization state for a drug pretty significantly depending on the situation. So as I mentioned, the aspirin overdose, aspirin's a weak acid. If I increase the pH by giving sodium bicarb, I can modify that Henderson-Hasselbalch equation so that way I have a lot more of it in that charged state, right? It's that unprotonated charged state, and that prevents that reabsorption. So that way they can go ahead and just urinate it out and not have to reabsorb it, and kind of prolonging their toxicity there. So we talk about clearance. We're basically saying like the amount of blood that we're clearing of drug per unit of time. So you can say like mLs per minute. That's usually the most common one. And it kind of describes all ways that drugs get eliminated from the body, whether it's renal, liver, biliary, everything. You kind of all combine it together to get this clearance total. The primary one, though, we're going to be talking about, it's going to be the kidneys here for our purposes today. And so we're going to see that clearance is a really important feature of how we determine drug concentrations, because it's not just what you put into the system, it's also how much you're getting out over that period of time, right? Because every drug has to get out of the body at some point. You don't want it to stick around forever, right? So what you're going to find is that the clearance from the kidneys is actually going to correlate pretty well to renal function. And so I'm not sure if you guys have covered anything about this yet, but we can basically determine renal function based off of something we call creatinine clearance, right? If you're not familiar, creatinine is a byproduct of creatine breakdown, which is a product of muscle breakdown. and we just naturally produce it at a pretty constant rate. You can have cases where it's higher or lower depending on the situation, but in general, your serum creatinine is going to be dictated mostly by your renal clearance. So you can find for like an adult patient, a normal value between 0.6 and 1.2 milligrams per deciliter. Don't memorize that number, but just know that's kind of general. And you can find though that someone with like renal failure, they might have a creatinine of like 3, 4, 5 in some cases. You find dialysis patients who miss their dialysis session have like a creatinine of 6, like it's quite high. The most accurate way to actually determine someone's creatinine clearance, though, is to do things like a 24-hour urine collection. You can actually collect all their urine for 24 hours and then determine what the concentration of creatinine is and figure out how much they expelled. That's not very feasible. Most people don't like to carry around a big jug of their own urine, so we actually have better ways to do that. And so this is where we use different equations to sort of estimate, based off of the blood level of creatinine, what does that equate to in terms of their actual creatinine clearance. And so here's just a couple of examples. Again, don't memorize these. Just know these are common ones you're going to run into in that clinical realm. And so the one he's most common for like adults is going to be the Cockcroft-Gault equation. And I really just want you to focus on some of the factors that go into determining that creatinine clearance, and as you might imagine, how this can affect drug clearance as well. So our creatinine clearance here, let's see, is creatinine clearance associated with protein in the urine? Absolutely. That's creatinine is a protein. So and you'll find that patients with renal dysfunction typically will spill out proteins in the urine. You'll find that the glomerulus is usually likes to prevent filtration of proteins, but over time as they degrade, you can actually start to spill protein pretty easily there. That's why you see like patients with like renal dysfunction, they may have like really foamy kind of urine. That has to do with those proteins that are there that are coming out into solution. It's a good question. So anyway, so looking at the creatinine clearance here, I want you to kind of have a feeling for where the different variables fit into this. So for instance, we have here in the numerator, we have the patient's age and then their weight. Notice that the older a patient gets, the smaller this number becomes. And so because it's in the numerator, as your age goes up, your creatinine clearance is going to go down, right? So what that means is what we just kind of naturally know. As you get older, your kidneys stop working as well. Someone who's 80 years old is going to have much worse kidney function than someone who's 20 years old, right? If all the other things being equal there. So age is an important factor. Their weight will also put in there as well in the numerator. So as this goes up, presumably they have more creatinine to produce more. It's trying to keep it sort of relative with the patient there. The other big feature though is in the denominator. You'll notice here that serum creatinine is there. So this is another thing that's inversely proportional. As your serum creatinine goes up in the blood, you're going to see that you're not filtering it very well and getting rid of it. Thus, you're going to see that the creatinine clearance goes down. So higher serum creatinine value typically means lower creatinine clearance. Okay. Now, an interesting thing here to note as well is for this particular equation, they multiply it by 0.85 if the subject is female. And you might ask, well, why would they do that just because someone is female? Well, if you think about general body composition between males and females, you can find that on average, you're going to find that female patients have a higher percentage of adipose tissue, less muscle tissue. And so in the study where they formulated this model, that's what they found worked best. This is how you could fit the data best. This also highlights some of the inherent limitations of equations like these, because you could have someone who is has much more adipose tissue than average. You could have someone who has a lot more muscle mass on average. So this does not always hold up, but it works for the most part for the average patient there. Here's another example of one where this works a little bit better for elderly patients, and you can find that we would never use Cockcroft-Gault for children because it just the data doesn't fit that model there. And so there's another one we'll use for kids. So just know that it's very patient population specific. But this one's kind of interesting because here again they're using serum creatinine, they're using age, they're also factoring in if the patient's a female. But this one's kind of interesting because if the patient's black, this actually gives you this actually bumps up your GFR or your creatinine clearance. We sort of use creatinine clearance as a surrogate for glomerular filtration rate. So those two you can kind of think a little bit synonymous, at least for our purposes here. So it just depends on the model, what factors they're looking at, but this is how they ended up fitting in their study the data to this particular model here. So just know that there's different variables, but in general, as your age goes up, creatinine clearance goes down, and as serum creatinine goes up, creatinine clearance also goes down. So looking at the normal values, for like a male patient, you may see like 120 mLs per minute per 1.73 meters square, but it can range, depending on many factors there. But this is generally around 100 or so is pretty average in terms of creatinine clearance. So anyway, if you recall, we talked about volume distribution. We're going to see that using volume distribution, which if you recall was basically how far out into the tissues that drugs partition, in addition to the clearance, this can give us what we call the half-life. And so as you might imagine, the half-life is basically going to be how long it takes for 50% of the drug to be eliminated in the body, right? And if you think about how blood flow goes in the body there, well, all my drug is going to be partitioned out into the tissue because it's really lipophilic. It's not going to be able to be in the blood as much to get filtered by the kidneys. So you're going to see how some of these different variables interact and how they're going to have an effect on the half-life. This is really important because patients' half-life can change depending on clinical situation. Between individuals, the half-life might change, and that's going to have a really important feature on how we dose drugs, how often we dose drugs, and things like that, right? So again, clearance is going to be determining the amount of drug eliminated per that unit of time. The volume of distribution determines how much volume has to be cleared, right? If something has really high volume of distribution, it could be 200 liters you're clearing. For something with a low volume of distribution, it's only like 6 or 7. Obviously, 6 or 7 is much smaller. It'd be easier to clear there. And this helps us how we determine our steady state plasma levels. And we'll talk about steady state much more here in just a moment. But in general, you can kind of think about drugs being cleared in two main ways. The majority of drugs are going to follow what we call first order elimination. For all you Star Wars fans out there, this is not a reference to that first order, but there is also a zero order elimination as well. And so they're quite different in terms of how this works. And I'll show you some graphs here that will make more sense. But essentially, in first order elimination, what we're going to find is that we're eliminating sort of a constant percentage of drug per unit of time. So maybe you're doing 10% of the total amount of drug in the body per hour, or 20% per hour, whatever the case may be. And this is proportional to concentration. So the higher the concentration, it's always going to be 10%. So I'm going to be metabolizing more drug if there's more of it around. I'll show you what this looks like on a graph, and it'll make more sense. In general, most drugs are going to follow this. There's also what we call a zero order or capacity limited elimination. This just means you're eliminating the same amount of drug per unit of time. So it doesn't matter how high you get the levels of the drug up, that proportion never changes. It's always going to be 20 milligrams per deciliter per hour for the instance here of ethanol. And so it's independent of concentration, right? So what you're going to find is that, this roughly equates with alcohol to 1 drink per hour, right? And so you can have someone who has 1 drink and in 1 hour they'll get rid of that. You can have someone who has 10 drinks. It's going to take 10 hours for them to clear that on average. And it all has to go with the fact that it doesn't matter how high the levels are, the liver can only do so much. The reason for that is because frequently you're going to be overwhelming the system, and it's going to be all those enzymes and all those things are going to be basically occupied, and so it slows down the elimination pretty quickly. So what this looks like on a graph, if you were to imagine clearance, you have time on your x-axis here, and then you have the drug concentration on the y. With zero order kinetics, it's the same amount per unit of time. It doesn't matter what the concentration is, it's always the same amount. This is actually handy. What we do in the ER, sometimes when you have people who are alcohol intoxicated, you can actually predict when they will become sober, basically by looking at their blood level and then just measuring out how many hours it's going to take for them to get down to a level less than 80, for instance, which is the legally drunk limit. In terms of first order, though, you're going to see here that it's a constant percentage of drug. So when the concentrations are really high, you're metabolizing a lot of that drug at first, but then as concentrations get lower, you're going to see that it kind of slows down. It's always the same percentage, though. Okay, this is really helpful when we're doing calculations, though, and most drugs are going to follow this first order elimination. Okay. So, as I mentioned, we're going to see that for first order kinetics, the renal clearance can affect this pretty strongly, right? So what we're going to see is that the concentration of the drug and the rate of the drug administration is going to be taken into account here, right? So we're going to find clearance is going to be equal to basically that rate of administration or the rate of drug we're putting into the system and then dividing that by the drug concentration. Now, again, we're not going to actually do many calculations based off of this. It's kind of the variables that I want you to understand and what's going into that. Well, how do I figure out what the rate of administration is? Well, it's basically the dose and the interval that I'm giving it, right? So the dose I know because I'm giving 500 milligrams, I'm giving a gram, whatever the case may be. And that interval is how frequently they're getting it. So it could be every 8 hours, it could be every 12 hours, every 24 hours. That's your interval, right? So those are two variables that will figure out how much you're putting into the system. And then you're dividing by the drug concentration. And so what we're going to see is when you have this proportional relationship that as the dose goes up, for instance, clearance is going to go up. As the drug concentration goes down, you're going to see that this is also going to lead to a larger clearance as well. So we're going to see how this is actually going to factor into it. So let's imagine we were having a drug that is eliminated at a first order and under a first order model, and it's 15% per hour, right? So every hour is going to be 15% of that drug's being eliminated. Let's say initially we just put in 1,000 milligrams, 1,000 milligrams right IV into the system here. During that first hour, you're going to eliminate 150 milligrams, right? So 15%, and you have 850 left over. Okay. Then that next hour, it's only going to be 127 milligrams eliminated. Still 15%. But because this total amount's going down, the proportion stays the same. It's just overall amounts are going to be decreasing, right? So 15%, 15%, 15%, down to where even at 5 hours, now you're only getting 78 milligrams metabolized in that hour, like half of that. But what you're going to find is it's always going to be that same percentage. So the more drug around under first order kinetics, the more drug being eliminated. And so what that looks like is on this graph here, you can actually calculate, well, at what point do we hit that 50%? At what point has half of that drug that we had in the system been eliminated? And this is what we're going to call is the half-life, right? So once that 50% is gone, that's one half-life. And then another 50%, now we got 25% of that drug left over. That's another half-life. Then we got 12.5% of that drug left around, another half-life, another half-life. And so you can see down toward the point where you get very, very small numbers until eventually the drug is just gone, right? So how we figure that out, so what that fraction, in that example we looked at, that 15%, what that fraction of that drug is, we use a value called KE. KE is the elimination constant that we're going to look at. And every drug has an elimination constant depending on the patient and things like that. And so basically what we can actually do is if we're looking at a graph, let's say we took a graph of drug concentrations. I measured someone's blood level over the course of several hours and plotted that on a graph. And let's say I'm going to take the log of the concentration. So that way it's not looking like one of those curves. It's just a nice flat line. Basically what I can do is I can actually take two values, and this is actually just like in your maybe back in your trig classes, maybe when you did this, when you're trying to figure out the slope of a line, right? And basically what you could do is you could take two values here, the peak and a trough as we'll call it, so peak being a high level and the trough being the lowest level we're measuring, and then dividing that by the change in time, right? So the change in the y-axis divided by the change in the x-axis. And notice here we're using the natural log because, again, we're going under this first order kinetics. And so that's how we calculate that, right? And so you may not do that in the clinical course of your time, but we do this all the time. We, especially if you go to a lot of hospitals, they'll have programs in place where pharmacy will be doing a lot of drug kinetics. And we do this quite frequently for certain antibiotics and things like that. Another way to look at this, though, is that KE is equal to your clearance divided by your volume of distribution. So this is a little bit more clinically useful because now you can think about, okay, well, if my clearance goes down, what happens to my KE, right? So maybe it was 15% before, but now it's gone down to like 10%. You can now see that you're going to be eliminating 10% of that drug per hour as before when it was 15%. That can make big differences in your overall level of the drug. Also, what you're going to see here is that VD is going to be on the denominator here. So the bigger this is, the smaller your KE is going to be as well. Because again, there's just more volume you'd have to clear to get rid of that drug. So it kind of makes sense in terms of how that works. And so I want you to think about the variables and how if those change, what that's going to do overall to your clearance there. So again, the half-life is just the amount of time it takes for the concentration to drop by 50%, right? So let's say we have a drug A and the concentration at 4 p.m. is 20 micrograms per ml. And then at 8 p.m., the concentration is 10 micrograms per ml. And so you say, well, what's the half-life? Okay, well, it went from 20 to 10, that's 50%. And it took 4 hours. So that means that drug has a 4-hour half-life. Okay, pretty straightforward. Let's say we took drug B and it has a concentration of 40 mics per ml at 8 a.m. and then the concentration is 10 mics per ml at 4 p.m. What's the half-life? Okay, well, if you look at that, you're like, okay, well, wow, it dropped 75%. But if you start thinking about it in terms of half-life, you think, okay, well, 40 to 20 is one half-life, and then 20 to 10 is another half-life. So it's had two half-lives. It's happened over the course of 8 hours. So 8 divided by 2, you have a 4-hour half-life. So it's actually the same between these two examples here. But you're seeing is you're just carrying it out for another half-life at that point. And again, so this is what we're going to see for the majority of drugs. They follow this first order sort of kinetics. And you're like, why do I even care about this? It matters because if you change what that KE is, if you change that half-life, the patient may have drugs sticking around for much longer than you expect. And then that can lead to levels building up, and eventually they can develop pretty significant toxicity. Or the opposite may happen. Maybe they're clearing it too well, and the levels are too low, and now you're not treating that infection, right? Maybe you're not treating that heart arrhythmia. So it kind of cuts both ways, where you want to keep the levels at the right amount, not too low or not too high, right? It's kind of like a Goldilocks sort of thing here. And again, what you can see is just every 50%, right, you're dropping it down. So by the time you've had two half-lives, you only have 25% of that original amount of drug left around, right? Now, again, you're going to find that oftentimes we're going to be dosing before we hit these really low levels in order to make sure we get sort of a steady level, a steady average level of drug in the blood all the time. Because, again, what we're going to find is that typically for like hypertension, we just don't want to treat that in the morning time. You want to treat it 24/7. And so that's why we do these repeated dosings to make sure that there's always some blood in the body, but we want to make sure we're not going to get too much or too little, as the case may be. To give you some examples of different half-lives, they can be extremely variable depending on the drug. I have two antiarrhythmic drugs here. For example, I have adenosine and I have amiodarone. Adenosine is actually used to treat supraventricular tachycardias. You'll learn a lot about this in your cardio class, and certainly we talk about this in Pharm 1. It has a half-life of less than 10 seconds, right? So it means in less than 10 seconds, that original dose you gave the patient, half of it's already gone, right? That's why it's really imperative that you give it very quickly to make sure that it gets to the heart, because if it degrades before it even gets there, it's not going to be all that effective, right? Versus something like amiodarone, which is used for a variety of different arrhythmias, has a half-life of like 26 to 107 days. It's pretty variable there, right? And again, you're going to see that it can take a long time to achieve really steady levels because of this long half-life. And so I'll show you what that means in terms of steady state in just a little bit here. But just know that drugs can have really widely different half-lives, and some of them may even be very patient-dependent. So one patient may have 26 days, another one may have 107 days, right? So I mean, it's almost like a four-fold difference there. So it can be quite significant in those changes. So how do we calculate half-life? And again, you're probably not going to have to calculate half-lives very often. You may have to look at two levels and give me a general idea of what the half-life is, for a test question, but I'll make it pretty easy. You're not going to have to bust out a calculator for this. But looking at this, what you can see is that KE, if we know the KE, we can basically plug this in. This is just kind of a known equation. If you do 0.693 divided by the KE, it gives you your half-life. But another way we could plug this in, because we know that KE equals clearance over VD, so what we can actually do is plug this in here to look at how VD and clearance are going to have an effect on the half-life, right? I more so want you to know what the variables are going to do here, because as patient variables change, you're going to see half-life change as well, right? So what you're going to see here is, look, clearance is now in the denominator. So what happens if clearance goes down? Well, my denominator is smaller, so this number is going to get bigger. That means half-life is going to go up. Well, that makes sense. I'm not clearing it as quickly, so it's going to take longer to get rid of it. Makes good sense. Volume distribution here is in the numerator. So if I have a higher volume distribution, that is also going to be increasing my half-life. And conversely, volume distribution is lower, it's going to be lowering my half-life. It's going to be faster to clear that because more of it's kind of concentrated there in the blood. This matters because imagine if I have a patient who I'm giving an antibiotic to and I want to make sure the levels are high enough to treat the infection, but not so high that I'm going to start to see toxicity. If they have, for instance, ascites, or if they have edema due to CHF or something, they're going to have a lot of extra water kind of stored out there in the tissues, and that means VD can possibly go up. So if I know VD is going up, then I also know my half-life is going to be going up as well. And so that means I may want to adjust how I'm dosing the drug to account for that, to try to avoid some of those issues, right? So what would happen, the larger VD we said would have a larger effect on the half-life. It'd have a longer half-life. VD goes down, half-life is also going to go down. And then if clearance goes down, again, it's going to cause the half-life to be longer. So keep these relationships in mind because I can ask you on a test question like, okay, this variable has changed. What effect is it going to have on the half-life? So I want you to kind of have, and again, it makes sense if you think about the physiology and think about what these variables mean. So it shouldn't be so harrowing. You should have an idea. Okay, well, if I know if a patient develops renal dysfunction and their clearance goes down, well, yeah, I know the half-life's going to get longer because they're just not clearing as quickly. So a lot of it is fairly intuitive, even if all these variables and whatnot seem to be a little, cause some apprehension in you. So there's another term we use in relation to half-life and elimination, all of that. It's called steady state. This is basically the point where the amount of drug I'm putting into the system is equal to the amount of drug coming out of the system, and the system being your patient there, right? And so this means, because most things follow first order kinetics, you're going to find that there's going to be an equilibrium point that is hit where the amount of drug I'm putting in, however often I'm doing it, is going to be equal to the same amount of drug coming out. So what I actually end up getting is a nice steady state, a nice average steady level of where my patient's blood concentration is going to be at. So on average, if I measure that patient's blood when they're at steady state, I should be able to get roughly the same value or somewhere right around there. And so the way we figure this out is our steady state concentration is going to be equal to the dose we're putting in and then divided by the clearance times the dosing interval. And that dosing interval is going to be usually in hours. So for a daily drug, it would be 24. For a Q8 hour drug, it would be 8 here, right? So you can see how already we can change this concentration pretty significantly either by modifying the dose or modifying the dosing interval. I can't really change the clearance on a patient for the most part, not unless I hooked them up to dialysis or something like that. So this one is going to be very patient specific, whereas I can change the dose and the dosing interval quite easily. So what you're going to see, what effect does dose have on the steady state? Well, if I increase the dose, then I should see an increase in steady state. It makes pretty good sense. And conversely, if I decrease the dose, I'll decrease the steady state concentration. It makes good sense there. What about the dosing interval, though? So again, if I'm using a smaller dosing interval, so say I went from 12 hours to 8 hours, I'm giving the body less time to clear that drug, right? So that means less time to clear it. This is a smaller number here. My denominator is now smaller. This means overall my steady state concentration goes up, right? So that's a really important factor there. So by changing how often I'm giving the drug, say if I went from Q8 hours to Q12 hours, now I'm giving the body more time to metabolize that drug, the CSS is going to go down, right? Assuming I keep the dose exactly the same here and clearance does not change for that patient. So, and I'll show you some graphs, and this will make more sense in just a few minutes here. But what you're going to find is that roughly it takes 4 to 5 half-lives on average for drugs to reach steady state. This is a really handy number to know because you're going to be able to look at the half-life of a drug and be able to determine roughly how long it's going to take before your patient gets to steady state. You may find the patients may not get a whole lot of therapeutic benefit until they are at steady state because that's that point where you get up to where it's effective without it being toxic, hopefully. So here's an example, and this is kind of bad because this is yellow here and doesn't show up good on the white, but you get the idea. So as I mentioned, steady state is where the input rate equals the elimination rate. That you're going to see is concentration on the y-axis and time on the x. And so imagine I were to give a drug via continuous infusion, right? So I go ahead and I'm giving that drug via IV. It's continuously running at the same rate over time. What you're going to find is that concentration will go up to a point, and at that point where the elimination is going to be equal to the input, that is the steady state, okay? And presumably, if that patient's clearance never changes and I continue that continuous infusion, I could run this for 10 years, assuming nothing else changes, I will get the same concentration, right? That's a steady state. What's going in is equal to what's coming out. If I were to end that infusion, then you would see normal elimination occur and drug levels would then drop off, okay? Now, it's not super convenient to do continuous infusions for all your patients because, well, then they got to be hooked up to an IV all the time, right? And that's going to provide some logistical issues. Most drugs are given intermittently, right? So every 8 hours, every 12 hours, every 24 hours. And so that's going to have some effects too. So if you were to look at, say, intermittent dosing, basically if you give that first dose, and you can see here start to drop down, and then at that next dosing interval, whatever time it might be. Then I'm giving another dose of the drug. So normally when you're giving a drug to a patient, the time you're giving that second dose, there's still some of that first one still left around. And that's good because that's going to help us get to that steady state. You wouldn't want to get all the way back down to 0 because then you never really hit a good steady state at that point, right? So you tend to see this dose stacking effect that occurs here intermittently that can be seen as sort of a analog to a continuous infusion. If that blue line would be what a continuous infusion would look like, right, to get the same dose over that period of time. But normally what we're going to do is intermittent dosing for most of our patients. And so what you can find is they will have peaks and troughs, right? They will have high values when they give a dose and low values right before the next one. But the average is what we're concerned with, right? The average steady state. We want that to be in range when we're doing things like, therapeutic drug monitoring on blood levels and things like that, right? What's really cool, though, I think, is the fact that we can modify this, right? So we can figure out ways to change the peaks and the troughs to make sure that we're staying in the range we want to be in. So there's 3 different dosing strategies here for this particular drug, right? So there's the continuous infusion, you can see right here. There would be one where we're giving smaller doses more frequently, say every 8 hours. You can see on this lighter gray line here. And then there's one where we give a very big dose, but we're giving it every 24 hours. Okay, you see that. So, if you're looking at patient compliance, like obviously a Q24-hour drug would be the most convenient for the patient, but let's see what are some of the downsides of that, right? So let's imagine that we have a minimum level required for the drug to be effective. Let's say that's right at 5 here, right? What do you notice about the drug that's given at a bigger dose more infrequently? Well, the drug levels drop down below that. Well, if I don't want that to happen because maybe the bacteria isn't killed off, if I drop my level down too low, that's going to be a problem, right? Because you notice these troughs are going to be too low here. On the flip side, though, imagine what if the concentration, what if the peak levels, if I start to get really bad toxicity at a level of 20, right? Well, now you can notice here that these bigger doses given less often are going to be hitting these really high peak levels, which may lead to significant toxicity there. So I can modify that, right? I can give the drug more frequently, but maybe more often, or I'm sorry, give more frequently but at a lower dose. And now you can find that I hit smaller peaks, higher troughs, but I'm still at the same steady state concentration, right? Now, for a lot of drugs, it doesn't matter. It doesn't matter if you give it 24 hours. These peaks and trough levels are totally fine. You're not going to run into any issues. But for some drugs, we have to give via continuous infusion because we want to hit the steady state level and be right there in that range because that's where it's going to be most effective for that patient. So it's always a balance, right, between compliance, what the patient's willing to do, what they're able to do, and just what levels those drugs need to get to be effective, right? So here's just another graph kind of looking at the same thing. You can see just different dosing strategies and how you can tighten up that difference between peak and trough depending on the level that you're administering there, how frequently you're going to be giving it there. This one is kind of good. This one on the right here is nice because it kind of shows you what just a single dose would look like if you were to give it and allow it to be eliminated versus if you actually do intermittent dosing, and you'll see that dose stacking that happens there where eventually you're going to get at steady state. So it's a fixed dose, but it's repeated intermittently, and that's where you get that steady state concentration, right? It's an average steady state, not that you're going to get the same level all the time like you would with a continuous infusion, right? So, well, what if, I had a patient with an arrhythmia and I wanted them to use amiodarone, right? I needed that amiodarone to treat their ventricular fibrillation, right? Well, we said that it ranged anywhere, its half-life between like 20-something to 100-something days. If it takes 5 half-lives to reach steady state for it to really be effective, that patient might be waiting around 100 days just to even get on the small side, even to get to steady state. So, if they're in VFib, chances are they don't have 100 days to wait around. They're probably going to be dead in a couple minutes here. So what can I do to get around that? Well, this is where we give what we call a loading dose. This is a large bolus dose that basically raises the the plasma concentration up to the average steady state, and then you follow that up with either intermittent or continuous dosing in order to keep them at that steady state. So if you were to look at this graph here, you can see a bolus dose, which is in red, and then you have a blue line, which is going to be the continuous infusion that is started at the same time. Basically, and then this black line is that steady state concentration. Basically, you give the bolus dose here. As it's being metabolized and being eliminated, the blue line is going to start to pick up the slack here and then allow us to keep the same average concentration this whole time there. So that's really beneficial. If you need something to work really quickly, especially if it's like an emergent sort of situation, that's where bolus doses are going to be used there, these loading doses there. Really, bolus just means anytime you're giving one amount of a drug at one time, but when you say loading dose specifically, that's what we're talking about, is a shortcut to get to steady state that much faster, right? And normally we figure out our loading dose based off of things like volume of distribution and total concentration. And so remember, to get that initial concentration, it's going to be based off the dose and the VD. So these are things we figure out in terms of how much dose we're going to need to get up to that steady state based on things like volume of distribution and things like that, right? And so we're going to take into account things like bioavailability, lots of other things that go into figuring out what's our loading dose and then what's going to be our continuous dose after that. So in the example of VFib, here's one called lidocaine, which is a local anesthetic, but is also antiarrhythmic. We do 1 milligram per kilo dose IV push as the bolus, as the loading dose, and then you follow it up with a continuous infusion, 20 to 50 mics per kilo per minute. That keeps us at steady state. Another good example, though, is I'm sure many of you have either heard of a Z-Pak or have taken a Z-Pak in your time. That's a drug called azithromycin, which is an antibiotic. On that one, all the Z-Paks, you take 2 pills the first day, and you take 1 pill once daily for another 4 days. Well, why do you take 2 on the first day? That's kind of like using a loading dose, right? Give you kind of a boost up in those levels to get to the point where you can start to kill off those bacteria. So that's another way we can do that without having to rely on things like IV doses and whatnot. And so that secondary dose, once we get that loading dose in, then we're using our maintenance dose. That's maintaining us at that steady state level there. So in that Z-Pak example, days 2 through 5, or just 1 tablet a day, that's the maintenance dose you would see with that, right? And so again, based off of this, we can figure out how much dose we need to maintain that steady state, and you can figure that out, right? Based off the clearance, how fast the patient's eliminating the drug, what concentration you're actually looking for, and then your dosing interval, right? And so this is important too, because if I'm trying to, for instance, if I have a patient who's in the hospital and you're trying to dose a drug every 12 hours, right? Nurses can probably keep up with that, even if they're busy on the med surg floor. They have a lot of patients to deal with. But if I wanted to decrease that dosing interval to like every 4 hours, like no nurse is going to be able to keep up with that. It's just too hard to do that with the typical patient load. So sometimes we have to use longer dosing intervals, but I still want to achieve that same CSS, so then I can go about doing that by changing the dose I'm giving, right? So if I'm having a longer dosing interval here, I'm going to need a bigger dose in order to achieve that same steady state. Okay, so again, these are some of the calculations that go behind the scenes when we're determining how much to give as both a loading dose and then as a follow-up maintenance sort of dose. Here's an example of an antiplatelet drug called clopidogrel or Plavix. Here's another one you can see where they actually get multiple large oral doses up front as a sort of loading dose in order to get them up to steady state, and then you can see the intermittent dosing done afterwards in order to keep them there. This is a drug given in cases where patients are going in for percutaneous coronary interventions, with having a heart attack and they're trying to open those vessels back up. You use antiplatelet drugs to prevent those vessels from being clotted off. So just another example how we can give loading doses to get them up to steady state, and then we're using smaller maintenance doses to keep them there, right? So looking at some of the different variables here. So let's say, for instance, that we have, given that our CSS is equal to the dose divided by that clearance times the dosing interval, what are some reasons we would have supratherapeutic concentrations? When I say supratherapeutic, I mean higher than what it would be considered therapeutic, right? So that's when we're going to run into toxicities and whatnot. Well, a couple of things here, right? So one could be that the dose is too high. That's a possibility. It's certainly been dosing errors in the past there. But what are some other things that might be issues as well? Well, if the clearance goes down, then I can see that because that's in the denominator, it's going to cause my CSS to go up. That's a big issue, right? So we see this quite frequently where patients' renal function will change over time, and that can cause the steady state concentration to be too high, for instance. Or if they're taking it inappropriately, like let's say, for instance, they were to take it too frequently, and I'm decreasing this dosing interval. Say they thought it should have been, or you said it, take it every 24 hours. They thought it was every 12 hours. That could then also cause these super therapeutic concentrations. So a lot of it's good patient education, or having means to make sure that as long as the dosing interval and the dose itself is kept steady. The other big factor is making sure you're monitoring for clearance. I can't tell you how many elderly patients I've seen come into the ER for drug toxicities because no one was watching the fact that over the course of 10 years, their creatinine clearance changed, right, and it went down. So those are definitely things you have to monitor for over the long term. So in terms of absorption, though, compliance is a big thing we want to watch for, making sure patients are taking things like they are supposed to. They're not skipping doses, making sure that they are not taking it with things that will interact with it that can maybe prevent absorption. Like we talked about some drug-food and drug-drug interactions there. And make sure that they're educated on things to not take it with, like grapefruit juice, which can lower levels of some drugs and increase levels of others, right? So it just depends on the situation there. In terms of clearance, really the big thing you're going to find is that as organs start to reduce their effectiveness, like with the kidney and the liver, you're going to see clearance is also going to go down as well. And so this is where you have to adjust drug doses for that specific patient. So someone with a creatinine clearance of, say, 100 may be dosed much more aggressively than someone with a creatinine clearance of 30, and that's all very drug specific. And you'll find that when you're looking at your drug references, you can go through and see, okay, well, if their creatinine clearance is this, here's how I dose it. If their creatinine clearance was this, I dose it less frequently or at a lower dose. Right, so you can kind of modify either variable there. And again, remember, in terms of like toxicities we see with these patients here, some of it may be related to the same mechanism of action of the drug, where you can see that identical receptors in different tissues can cause some of these toxicities. So for instance, if you're looking at like opioids, the constipation that happens there is through the same receptors that cause analgesia, right? You have opioid receptors in the spinal column, and in the brain that help with analgesia. You have opioid receptors in the GI tract that causes constipation. That's through the same mechanism, through the same receptors, just in different types of tissues there. Sometimes you may find, though, that drugs can work on multiple types of receptors, and that can sometimes lead to some of the issues you run into as well. A good example is erythromycin, which is a antibiotic. Normally it works on bacteria to kill them, right? What we actually find is that some toxicity you can get from that is that it actually works on the motilin receptor, which is found in the GI tract. It actually increases GI peristalsis. So as you might imagine, that causes a lot of abdominal cramping and diarrhea potentially, right? So remember, the toxicity can be kind of mediated through both ways. Sometimes the same mechanism, sometimes a different mechanism than what you would usually use it for its purposes. And keep in mind, other reasons why you might find super therapeutic concentrations that lead to toxicities could be things like intentional reasons. Maybe they're abusing it because it makes them feel good. Sometimes they try to take things in too much because they want to harm themselves, depending on the situation. Oftentimes, though, it can be unintentional too. So, for instance, like kids get into medications if they're not being stored appropriately, or they send a grandchild over to grandparents' house and their place is not child-proof, things like that. Or more often than not, we're going to find that impaired clearance due to changes in age and renal function are also going to be a big role to play here. And remember, every drug is toxic, right? It just depends on the dose you're giving there. Everything can be a poison, even oxygen, even water, anything can be poisonous at the right dose. And again, you're going to find that when dealing with these substances, most substances don't have an antidote, unfortunately. And so the best thing you can do is just give it time. So you want to be really cautious when you're giving a drug to a patient. You're considering, what's their clearance? What's their volume distribution? Is this different than another typical patient? And have I adjusted the dose to account for that? Because once you give it, chances are you're not going to be able to get it back. And so the best thing we can just do is give them time to clear it on their own and then provide good supportive care in the meantime. So really got to be cautious. Anytime you're giving a drug to a patient, really think about it to make sure it's appropriate for that particular person. Okay. So if you have any questions on that section, go ahead and feel free to post it up here. And I'm going to go ahead and get into the next one. Let's see. There's a bioavailability talk. And let me look at the sticky board, see if there's any questions on here in the meantime. Oh, I have 2 questions here. It's fantastic. Okay, I'll start with the small one first. Is loading dose only used for drugs with large half-life? Not necessarily. If it's something to where you need to get it up to that concentration like immediately, really quickly, because it's maybe a life or death sort of situation, then yeah, that's where you're going to be using your loading doses most commonly. The other place where it's used most commonly is for those drugs with really long half-lives. So the amiodarone is a really good example there, where it usually will start off with a big bolus dose, big loading dose, and then we'll follow up with a continuous infusion, and then eventually switch them over to like oral dosing, for instance, if they're going to stay on it for a while there. This next one, in finding the steady state of a drug, is it just as simple as multiplying the half-life by 4 or 5, or are there other variables to account for? That's a good question. In general, yeah, multiply by 4 or 5, you'll have a general idea of how long it's going to take to get to steady state. There are other variables you'll try to account for depending on your patient, though. So if they have poor renal function, that's going to change it. If they have liver dysfunction, it may change it. If they're obese, it may change it. So there's a lot of factors that go into it. But like for instance, with our drug assignment question, which I'll talk about in a little bit later, you can assume you have a normal, typical patient you're dealing with. Normal is kind of a bad term, but a typical average patient from when they came up with those values that you'll see in the drug references and whatnot, right? So hopefully that answers that. Nothing else in the chat. So let's go ahead and move on to bioavailability. All right, so this is kind of a hodgepodge of topic. I want to get into some math here at the end as well. So when we talk about adverse reactions, what are we talking about? Basically, it's any kind of like appreciably harmful, unpleasant reaction that's going to be as a result of using a medication, right? And it may lead us to need to stop using that drug altogether. It may require us to change the dose. It may require us to maybe add on another drug in order to manage that. Now, in general, you never want to use a drug to treat the side effect of another drug, but you'll be surprised how often that actually does come up. And so we kind of can break these down into 6 different categories in terms of how they can be arranged. So I'll talk about these, kind of use like an A, B, C, D, E, F mnemonic, and I'll get into these specifically as we go forward. But you can kind of reference back to this. So when we're talking about dose-related adverse reactions, these are quite common. This just means the dose is either too high that you're getting there, and it's expected side effects that okay, if I give too much of this drug, I can predict this is going to occur. This is generally low mortality overall for the most part. But imagine you see someone who you give an antihistamine to, like Benadryl, they get sleepy from it. Okay, I expect that to occur, especially with bigger doses. If I give someone an antihypertensive and they get too much and they have hypotension, that's expected, right? Hypoglycemia with insulin. Those are all dose-related sort of issues there, which can be treated just by decreasing the dose, right? By modifying it for that particular patient. Sometimes, though, you get what we call like non-dose related effects. These are fairly uncommon, and they're typically not related to the pharmacologic action. And so, since they are so unpredictable, they tend to have a little bit of a higher mortality there. So here's a good example of like an allergic reaction to penicillins. I can't really predict who's going to have an allergic reaction unless they have some sort of history with it. Or another good example would be certain patients they have a genetic predisposition, have this really bad reaction to certain anesthetics or a certain a paralytic agent. It's called malignant hyperthermia. And so you may go into surgery and the anesthesiologist starts to give them the inhaled anesthetic, and all of a sudden their blood pressure's up and their temperature's up, and they can possibly die from malignant hyperthermia. So you gotta be really it's just unpredictable. You don't know who's going to have it. So sometimes you can get around this by actually like asking screening questions beforehand, especially like in some patients with like high risk history. We'll go ahead and ask them, hey, does your family have a history of bad reactions to anesthetics? And we'll actually give them, we'll run a test for them. But it's so rare that we don't test the majority of patients for it. So that's another tough one to catch. Sometimes you're going to find that things can be related to not only the dose they're receiving, but also the time that they're on it. Some more chronic issues that will pop up. And they're relatively uncommon, but it has more to do with the cumulative dose and the amount of time they're on the drug. So as an example with this, a common issue you run into with patients who are on corticosteroids, so things like prednisone, dexamethasone, things like that. When they're on them for a long period of time, you can actually find that you can cause adrenal suppression, right? The body, when it detects that there's enough steroids around, your adrenal glands want to shut down. They're like, okay, well, I don't need to do anything because I have enough steroids around. It's part of that negative feedback loop. And if you were to take those corticosteroids away from that patient, then all of a sudden they can go into adrenal crisis because they're not producing their own steroids, hydrocortisone and things like that. So again, it has a relation to how long they're on the drug for. If you take 2 or 3 days of a steroid, you're probably not going to run into this. But if you're on it for weeks to months to years, then absolutely it's going to be a big issue. Sometimes we'll find things can be time related, meaning there's more so to do not with the dose of the drug they get, but just how long they've been exposed to it. So it usually does not become apparent until they've been on it for a long period of time. So this could be an example, like say for instance, you had a patient who had bipolar disorder and they're on a drug called valproic acid, and they get pregnant. They don't know that they're pregnant for a long period of time, which can happen. It'd be nice if all these lights and tiny cherubs with harps came down the second someone got pregnant. It'd be pretty good early warning sign, but a lot of people just don't know. And so you can actually find teratogenesis, or actual birth defects, and things like neural tube defects that can occur in that developing fetus. Another one would be patients who are on certain classes of antipsychotics. They develop something called tardive dyskinesia, which just occurs over the course of time, where they have these like really abnormal movements. They have like things like tongue smacking and usually a lot of facial tics and things like that can develop over time. And again, all this is related not to the dose they're getting, but just how long they've been on it for. And sometimes this stuff can take years to manifest. Withdrawal is a good one, where patients who are on a drug for a chronic period of time, if you remove that drug, then you end up having an issue. Like, so for instance, with things like opioids, this is a common one. Or I've mentioned that beta blocker example previously, where if you have someone who's on a beta blocker for a long period of time, they upregulate those receptors, and if you take that away, all of a sudden the heart's much more sensitive. You can have like rebound tachycardia, and even MI can occur in some cases there. Some ways we can actually get around this, because we know some patients might be at risk for poor compliance and not taking drugs like they're supposed to, and so we can sometimes get around this by using drugs with like really long half-lives, for instance, to try to prevent withdrawals. So if you've ever heard of the drug methadone that sometimes we use for opioid use disorders, that has a really long half-life, like 50 some odd hours, so that way someone hopefully will not have to endure opioid withdrawal, help to ameliorate some of those withdrawal symptoms in order to prevent them from going back and using whatever opioid they normally use, heroin or oxycodone, whatever the case may be. Right? And then there's unexpected failure of therapy. This is going to be usually related by things like drug interactions, or maybe we're giving an insufficient dose, or there's some interaction occurring that's causing an issue. So a good example would be like if a person's on a fluoroquinolone antibiotic and they were drinking it with milk, right? The drug's not working because it's being bound up in the GI tract and being just pooped out, basically, right? That's not going to work very well. So that's one reason. Another good example would be oral contraceptives. This is a big one where you can actually find that if you have enzyme inducers, like actual liver enzyme inducers, this can actually increase the metabolism of things like estrogen pretty significantly, such that it helps to normally estrogen as oral contraceptives suppress ovulation. It can actually eliminate the drug fast enough to where actual ovulation can occur. And as you might imagine, you get a surprise pregnancy, right? I'd consider that a pretty big adverse reaction if you were not intending to get pregnant in the first place, right? So when you're looking at adverse reaction versus side effect, you'll find that a lot of people will use the term sort of interchangeably. Typically, side effect is something that's undesirable, but you can kind of live with it for the most part, right? Usually it's in addition to the normal therapeutic effect. Like if I take Benadryl, my allergies are going to clear up, but I'm going to get kind of sleepy, right? That's kind of a side effect. Adverse reactions you kind of think about as being a little bit more significant, a little bit more serious, life-threatening potentially. But side effects can sometimes be a good thing, right? So if you've ever heard of the drug called Latisse, which is the generic bimatoprost, it's actually used for glaucoma. That was its original use, but they realized it causes eyelash length increases. And so now it's frequently used for aesthetic purposes to increase eyelash length and volume and all of that. But you may find they can actually turn the iris brown. So that might not be very favorable, especially if you have patients with blue eyes, right? So that's pretty undesirable. But if the patient has brown eyes, maybe they don't care so much, right? So these are things that's always taken into account with your individual patient, what's good for them, what's not good for them, etc. When you're looking at something more significant like an adverse reaction like Stevens-Johnson syndrome, this is a skin condition you can get with certain antibiotics and certain other drugs. One called Bactrim is pretty notable for causing this. You can see how it causes significant rash, urticaria, it causes like serious skin sloughing. Basically, this can be quite fatal if not caught early and sort of managed with good supportive care here. That's an adverse reaction, right? That can be potentially deadly. A side effect, though, for some drugs with Bactrim, sun-exposed areas may be a little photosensitive. May wear some extra sunscreen or cover up. So again, they are kind of on a spectrum, but you'll hear some people use the term interchangeably. But in general, this is what I'm referring to when I say side effect versus like a true adverse reaction. Some other good examples of this. So there's a drug called Viagra, otherwise known as sildenafil is the generic name here, typically used for erectile dysfunction. A side effect, they get some upset stomach. Has to do with it causing smooth muscle relaxation on the lower esophageal sphincter, right? Causing some heartburn. Adverse reaction, sudden loss of vision. I'd say that's a lot more significant. This is sometimes irreversible. That sounds more problematic than just having an upset stomach, right? Lisinopril, which is an ACE inhibitor, frequently used for a lot of cardiac conditions, including hypertension. Side effect: they get cough due to a buildup of a product called bradykinin. It can be pretty problematic for some patients. I have family members who had to go off of an ACE inhibitor because the cough was driving their wife crazy, right? Angioedema, though, is a much more severe adverse reaction that can occur here. As you might imagine, this tongue getting that swollen can close off the airway pretty easily and cause death, right? So again, you can kind of see the difference between just a general side effect versus adverse reaction. A side effect may still cause you to stop taking the drug, but it is likely not to be fatal. So another thing I want to talk about is how we prevent adverse drug reactions. And so one of the things we'll talk about is the 5 rights. And these things sound so silly to talk about because it's like, well, give the patient the right drug. Well, no duh, but oftentimes you can find that it becomes much more difficult than you might imagine in the real world, right? So the 5 rights I'll talk about here include the right drug, patient, dose, route, and time. And I want to talk about some reasons why this may be difficult. So with the right drug, you can find... there's a lot of confusion with things like brand names and things like that. You can have the same drug that is an XR product versus SR versus ES, and it can be difficult to know which one you're dealing with, especially when you're trying to get history from a patient, and they don't even know the difference themselves, right? They just say, okay, I take this drug. You're like, well, is it XR or SR? Because it actually matters, because one's once a day, one's twice a day, and they're like, I don't know, just take the drug. That can be problematic, right? People say NyQuil or Tylenol. Well, those are brand names that they use to refer to a ton of different products out there in the over-the-counter market. Which one specifically? Tylenol may have Benadryl in it, right? NyQuil could have all kinds of different products in it that may be significant for your particular patient at that time. Not only that, but especially being in Orlando, back when travel used to happen before the COVID times, we have a lot of foreign patients who would come here because this is a big travel hub. And you'd have them come to the ER potentially, and they'd have foreign medications there. You have a lot of patients who are coming from Brazil and have like Portuguese medications, trying to figure out what the heck it is. Sometimes you can figure out by context clues, but sometimes it can be more difficult. So here's an example here of some English, well, I shouldn't say English, it's probably a bad way to say it, but what we use in the U.S., for instance, we use like albuterol inhalers. We use acetaminophen. If you were to have someone come in from the UK, they call it salbutamol, or they call it paracetamol. And so it's good to know some of those common ones, or be able to at least Google and translate based off of that. Like, that's what I usually do with like Portuguese medications or Spanish medications. I'll go and I'll just Google it, and usually Google will tell me what the right answer is in terms of what drug I'm even dealing with in the first place. So right patient, name alerts are really important, especially in dealing with pediatrics. I work over at Nemours Children's Hospital. It can be tough. You have twins who are in the same last names, could be in the same room. I always get really frustrated when in the NICU we have some twin rooms, because it's good and healthy for twins to be in the same area. You'll have basically room A and you'll have room B, right? So the same room, but it'll be 5113 A and B. Sometimes when twins are born, they don't have names yet, and so they get marked down as twin A, like baby boy A and baby boy B. And so you think it makes sense to put baby boy A into bed A and baby boy B into bed B, but sometimes they flip them around for whatever reason. I have no idea. Maybe to make it more difficult and provide some challenge to our jobs. But med errors can happen, right? So how do we get around that? This is where we use a lot of barcoding technology to make sure that we're scanning to make sure that we have the right patient that we're giving the right med to, right? And again, be cautious when you start to refer to people as numbers. Give that med to 5113. Well, that patient may have changed over 10 minutes ago, or especially in an ER when it's really fast turnaround time. That patient that was there an hour ago may be long gone, and so you could be giving the wrong med to that new patient who is there now. In terms of the right dose, making sure that we are dosing based off of things like their age, their gender, their renal hepatic function. All of these things really play a role here in terms of making sure we're getting the right dose. And you want to be prospective about this. You want to give them a random dose and then figure, okay, well, that was too high. That would not be great, right? And also make sure that when we're reconciling the home medication list, it's really, really important that we get a good, accurate list here. This is easier nowadays, mainly because we have a prescription drug monitoring program. here. Every provider can sign up for in Florida, which is great. But I'll give you a good example of an issue that popped up at a large hospital in town. They have a MedRec program where basically a pharmacy technician will go and get the medication list from the patient. They'll take it back to a pharmacist who will look it over. If they have questions, they'll go and talk to the patient. And then they'll then say, okay, this looks good, and they'll send it up to the provider. So what happened was he had a patient who was on methadone, who was a little less than honest in his recollection, and said, "Oh, I'm on this dose of methadone." It was pretty high, but it wasn't anything that would be considered completely out of the realm of possibility. So the pharmacy technician goes and writes it down. They don't know any better because they don't really have any clinical background. They bring it over to the pharmacist, and the pharmacist looks at it and says, "Oh, it looks pretty high, but it looks, it's not completely unreasonable." So they don't do any further checking on it, right? Then they send that up to the provider who's admitting the patient. Might be a PA in this instance, right? Could be a doc. And they say, okay, yeah, everything looks good, and we'll go and sign off on it. So then they reorder that home medication. So what do they find the next morning? Well, the patient was passed out in their bed, had to give him Narcan to wake him back up because he lied about the dose and he wanted to get some extra. That's not to say that everyone on opioids is going to lie, cheat, and steal to get their medications, but this is just one way of people being disingenuous. And if you don't do the right checking to make sure that that's what they're on specifically, you can run into problems, right? So make sure you always double check this stuff. In terms of the right route, you want to make sure it's being given via the right route. It makes sense, but this can lead to some pretty big issues. If done incorrectly. Like, for instance, there's a chemotherapeutic drug called vincristine. If you give it intrathecally, it can be fatal. And you're like, well, that's pretty hard to accidentally give something intrathecally. Well, the thing is that at the same time they're getting IV vincristine, frequently they're getting intrathecal medications at the same time. So if you were to, say, mix up the syringes, that could be fatal, right? So we do things to make sure that does not occur. Sometimes, though, you can use medications in like non-traditional routes. So, for instance, sometimes if we have impacted cerumen in the ear, we can actually use a laxative like Docusate, and actually will kind of loosen it up and allow us to flush it out. Sometimes we can have in the past given oral products intravenously. It's very rare, but it's something you may do on occasion there. Not only that, but routes being given via the wrong or medication being given via the wrong route can lead to severe tissue issues as well. So, for instance, there's an anti-epileptic called phenytoin. If you give that intramuscularly, it can cause significant tissue irritation or necrosis. Vitamin K can do this as well. So this is why you want to make sure that if it's only good via certain routes, then you make sure you follow that. And then timing can be pretty important here too. Let's see. Katie says, from my understanding, in the ER, providers and pharmacists have access to a database where they could check that what drugs and doses patients have been prescribed for the reason that some of them aren't honest. How does that work? So, good question. That is that prescription drug monitoring program I mentioned. There's a system nowadays called eForce. EFORSCE, you can look up, and that allows basically every controlled substance. So every opioid, every ADHD med, all of that gets reported out from the pharmacies into this database. And providers, and actually the law now states that anytime you're writing for a controlled substance, you have to look this up. Although how well that's reinforced, I don't know. Enforced, I'm not sure. But basically you have to look it up, and you can see if patients have been filling at, if they come in and they're saying, oh, my, got rid of, or all my medications are missing. I don't know where they went. And they just filled like 200 oxycodone, at 2 different pharmacies over the past 2 days. That can make you think that things are not quite so legitimate. Or you may find that everything looks totally correct on their profile, and you may think, okay, yeah, they do have legitimate issues. So, that's a good one. We'll talk more about that when we get into controlled substance later on. But good thing to think about. Anyway, timing of medications can be really important too. So, for instance, like patients who are taking acetaminophen too frequently for pain can lead to significant hepatotoxicity, right? If they're taking pain medications too often because they're in pain, that can lead to sedation, right? Now, imagine someone needed emergency contraception. Let's say someone needed to use Plan B, which is a form of emergency contraception you should take if you don't want to get pregnant. If you wait too long on that one, that can diminish its efficacy and lead to pregnancy, right? Or even antibiotics given too infrequently. So imagine someone who was taking antibiotics for a while. They said, oh, I'm starting to feel good, and they take them less and less, or they just stop taking them altogether. That can lead to worsened infection. That can lead to resistance. It's a lot of issues. So make sure they're taking everything right when they're supposed to, consistently. Otherwise, you may run into some problems there, right? So another thing I want to touch on real briefly is this term bioequivalence, which we've mentioned previously. This comes into importance when you're talking about medications that are being given as generics versus brands. Remember, the brand name has like a 20-year patent where they can sell themselves as the brand name, and then no one else can do that. And then once that 20-year patent has elapsed, then generics can come through and say, okay, I want to start making this drug as well. In general, is much cheaper, which is fantastic because it's good savings for the patient. But in order to be sold as a generic, they have to show that they are bioequivalent, right? They have to make sure they're showing that it's the same strength, the same route, the same dosage form, and then in patients they achieve similar levels as the brand name drug would, right? And so you can find this bioavailability, especially for a lot of oral products here, can vary, right? So it can vary based on the route of administration. It can vary based on the acid-base environment, both of the drug and the environment it's going into, the first pass effect. All these things are really going to be affecting bioavailability pretty significantly. And as you recall, we know that the IV route has the best bioavailability because you're putting it right into the system. But when you start to get into the oral realm, which most drugs are going to be coming in, anywhere from 5 to 100%, right? So some of them may not even be viable via the oral route because of the fact that the bioavailability is so low. So it's really just going to be dependent on the drug you're dealing with and the route that you're giving it, right? Not only that, but recall that the acid-base status is going to be affecting this pretty significantly as well, too, right? If I put a weak acid into an acidic medium like the stomach acids, I'm going to get much better absorption because like dissolves like, right? If I put a weak base into a product in more neutral to basic conditions like the GI tract and the small intestine, you're going to get better absorption, right? So that's always a key thing to remember, that is like dissolves like. And every drug is a little different. You may find things that vary greatly. As I mentioned, acetaminophen being a weak acid, pKa 9.5. This is telling me that's the pH you'd have to get to in order for there to be a 50-50 split between the protonated and the unprotonated species there, the charged and the uncharged species. In this case here, that's a pretty basic solution, right? The 9.5 is fairly basic. So that means that if I get down to a pH of 2, I'm starting to deal with acetaminophen. I should be looking at aspirin here. Let's say we're still dealing with acetaminophen. Let's say that pKa is at 9.5. That means if I go ahead and put it into a more acidic solution, so I get down to like a pH of 7, more of it's going to be in that protonated, uncharged state. It's going to have an easier time being absorbed. If I go even lower than that, let's say like the stomach, I'll have a very easy time absorbing that, much more so than if it was at a pH of like 10, which would be hard to achieve in the body, but just to give you an idea of what that looks like. And just remember that water is polar, right? And so the more charged something is, the more it's going to be able to be soluble in that water. Now, it's still important for things to be soluble in water for it to even go into solution in the first place. So you can't have things that are completely insoluble because it's going to lead to some issues there. But remember that lipophilicity is also really important for it to be able to cross those membranes in the first place to even have any bioavailability. And the more uncharged it is, the more lipid soluble is going to be able to cross over, right? Again, showing you something like sodium, which is very polar, just a positive charge on that, how it's going to be located and surrounded by water, very soluble in water. Here's an example of a polar bear. You have to be very careful of dipping them in water because they're just going to dissolve away, so it's not great for them, right? So as I mentioned, with aspirin being that weak acid example there, we said that like dissolves like. So especially when you're in the state where you have high hydrogen ion concentration, when you have something that's in an acidic medium, it means that you're going to be putting aspirin into that state where it picks up that proton, right? Just because there's more protons around, it's more likely to pick it up. And so you're going to find this is the neutral state for aspirin, and this is going to make it much more lipophilic as opposed to having this big negative charge on it like you would see with like a more basic sort of solution there, right? But as opposed to something like pyrimethamine, which would be a weak base here, you're going to find it's going to have an easier time getting absorbed in more basic solutions because when it's unprotonated, remember, it's not going to have that charge on it. Versus if you were to put it in more acidic solution, it picks up an extra proton here, and that charge makes it very difficult for it to cross over on its own, right? And using that Henderson-Hasselbalch equation is going to help us to determine, okay, is it in the protonated species, unprotonated? Does it have that charge or not based off of whether it's a weak acid or weak base? The big thing to remember from this graph here, too, is that when the pH is equal to pKa, it's 50-50 split, right? So you're not going to have basically 50% is unprotonated, 50% will be protonated here at that pH, right? That's why it's important to know, like, okay, well, aspirin is at a pKa of 3.5 versus something else like being at a pKa of like 7, for instance, right? Because again, when I'm looking at that difference between pKa and pH here for the given drug, I can then figure out what that ratio is going to be from protonated to unprotonated species there. And remember, when it's protonated and it's an acid, it's easier to absorb. Unprotonated bases are going to have easier time to absorb here. So you basically put the pKa in for whether it's a weak acid or base, doesn't really matter. You just pop it in here, and that will be able to tell you that ratio. And again, I use that my purposes too, because like when I mentioned the aspirin example in elimination from the kidneys, I like to put aspirin into a basic solution because that means it's going to be unprotonated, it's going to have a charge on it, and it's going to be easier to eliminate from the kidneys because it doesn't get reabsorbed in the nephron, right? So again, sometimes we can use that like dissolves like principle the opposite direction and really help us out in terms of like eliminating drugs faster, for instance, okay? And again, remember, elimination is primarily through the kidneys, but also the biliary tract is going to be really important as well. And so we're going to find that weak bases tend to be excreted faster in the urine, as I mentioned. In acidic urine, weak acids are actually excreted faster in alkalotic urine. Some people have tried to modify this or try to take advantage of this to try to pass urine drug screens more quickly. I've seen some examples in movies and heard some personal anecdotes, not me personally, but from people, where they try to use things like vinegar to try to help eliminate drugs faster from the urine, so that way they don't test positive on a urine drug screen. Usually that stuff's not going to work here, but as I mentioned in the aspirin example, that's a good one where I can utilize the Henderson-Hasselbalch equation to my benefit and for the patient's benefit to clear that out faster. I mentioned urinary alkalization is a good one. You can do that with really any weak acid. We're trying to eliminate even faster. Another one that I've done this for as well is a drug called phenobarbital, which is an anti-epileptic drug that can be pretty dangerous in overdose. And by go ahead and putting it into a more basic solution in the urine by giving sodium bicarb into the bloodstream, that then alkalizes the urine, that actually allows for it to be eliminated that much faster. So again, another way we can do that, similar to the aspirin example. So I want to kind of look at a couple of things here. So let's look at bioavailability. Let's kind of take into account things like first pass effect and all of that. But let's say we're dealing with propranolol. We mentioned this is a beta blocker. You're giving 160 milligrams, 1 tab PO daily, right? So propranolol is a weak base, I'm telling you that, and it has a pK of 9.4. So based off of this, do you think it'd have pretty good absorption in, say, for instance, the stomach acid? Well, just in the stomach acid itself, you would see that, okay, well, I know that, pH of 2 is a lot far below the pK of 9.4. I know a lot of this would be in the protonated form, right? It's going to be picking up, it's a weak base. I know that when it's protonated, it's going to have a harder time being absorbed. So it probably is not going to get absorbed from the stomach all that too well, but once it gets into the small intestine, pH starts to pick back up, then we're going to find that its lipophilicity is going to shine and will allow for it to have pretty good absorption. So you can see that depending on where you're at in the GI tract can have an effect on how well it gets absorbed. Now, with the first pass effect, we actually find that approximately 25% reaches the systemic circulation, right? So why is that? Well, that's because the liver is metabolizing approximately 75% of that dose, which sounds not great, but that's why we're dosing it at this level, so that way we can make sure that we can overcome that, because we know that only 25% gets across, right? So again, how much of that actually makes it to the systemic circulation? Well, 25% of 160 is just 40 milligrams, right? So of that initial 160, only 40 milligrams actually got into the system. Okay. I also know that by looking it up, propranolol has a half-life of 6 hours. So for instance, if I know that 40 milligrams were to be in the system at hour 0, I know that in 6 hours I'd have roughly 20 milligrams left. In 12 hours I'd have 10 milligrams left, and so on and so forth. So you can kind of estimate how much drug is actually around, especially when you're looking at some drugs. You'll notice they get less effective further on in their dosing interval, and a lot of it is related to that elimination that is occurring here, right? So also, if you're looking at the distribution of a drug, right, because I kind of want to look at this whole kinetic thing kind of from soup to nuts here. Looking at the distribution, you can see that propranolol is approximately 90% of its circulating is bound to plasma proteins, and this one specifically here, alpha-1 acid glycoprotein. So what does that do to the volume of distribution? Well, if you recall, we would see that drugs that are bound to tissue or bound to plasma proteins aren't available to partition out into the tissues there, right? And so what we can see here is that of that 40 milligrams in the system, 90% of that is actually bound to protein. 4 milligrams of it is actually free, right? And one thing I want you to know is that anything that is unbound is considered to be pharmacologically active, right? Because that 36 milligrams sitting there on the proteins is not going to be all that effective, right? Because they're not affecting things like the heart, for instance. But that 4 milligrams, this is what's actually pharmacologically active. And you can see too how some interactions can pop up. Imagine if I had less alpha-1 acylglycoprotein around. Well, this fraction would change here, maybe 20/80, and all of a sudden I have now 8 milligrams. And you can see you could double the pharmacologic effect there. So you're going to be careful there, because that can lead to some issues in terms of like drug interactions and getting too much of an effect or too little, depending on the situation. So let's say, for instance, we're going to I want to try to illustrate some of these concepts here in terms of these variables. And again, I'm unlikely to make you do these specific calculations on the test, but I do want you to at least have an idea of how these different variables are going to factor in, right? So let's say, for instance, we have a 70-kilo male. We're administering a dose of 160 milligrams per pranolol, and the amount in circulation we know, based off of first pass effect, is only 40 milligrams. So we're going to use that as our dose. The concentration in the plasma is 0.14 milligrams per liter. What is the volume of distribution in liter? And then what's the volume of distribution in liters per kilogram? Okay, so basically what I can do is I can factor in all these things here. So I can know my C0, I know what that is. I know what my dose is. I'm just trying to solve for my VD. And again, for the most part, if you can do simple algebra, you can do most of the math in medicine. So if I rearrange this, I can say that VD in liters is equal to my dose over my C0. Okay, well, go ahead and putting that in, I can see that 40 milligrams, which is my dose, over my C0, which is 0.14, I end up getting the X equals 286 liters, okay? That's a volume distribution. Now, that's for that particular patient, that 70 kilogram male. What if I wanted to take that and then apply it to someone else, say a 50 kilogram female, for instance? Well, I go ahead and just divide this out by the patient's weight, so I end up getting 4 liters per kilogram. So if you recall back on that list of different volumes of distribution, anything greater than 1 is considered to be pretty lipophilic. It's going to have a high volume of distribution. So in this case here, we can see, yeah, propranolol has a high volume of distribution, just based off of this. Even though that a lot of it is protein bound, we can still see that whatever is there can still partition out to the tissues fairly easily. So that's good to know, right? Because then I can take that and apply it to someone else. So let's say we had that 50 kilogram female, and I'm giving them a dose of 120 milligrams, and I know that the volume distribution is 4 liters per kilo based off that previous patient. What is the plasma concentration I can expect to get from them? This is useful because I can tell me, is the dose that I'm giving, is it going to achieve a sufficient level to be therapeutic, or is that level going to be too high and cause toxicity, right? So basically what I'm going to go ahead and do is try to solve for C0 based off of the dose and the volume distribution. So looking at that, again, I have a 50 kilogram female, administered dose is 120, my VD is 4 liters per kilogram. What's the plasma concentration? Okay, for one, I know my dose is only going to be 25% of what I actually gave, so this can turn into 30 milligrams here. And then I know my volume of distribution is going to be 4 liters per kilogram times that 50 kilograms. So now I know that my volume of distribution for that particular patient is 200 liters, which you can see right here. So now my dose divided by 200, so 30 over 200, I can estimate that that patient would get a level of 0.15 milligrams per liter. And if I can look at the therapeutic range and see that it's in range, then I know that's a good dose for that patient there. Which makes sense because, we have someone who was 70 kilograms before, they got a dose of 160 and they got a level of 0.14. And then we gave this patient here a dose of 120, they got almost the same level, right? Because against a smaller patient, but the kinetics of it stay roughly the same. Okay, so hopefully that makes some sense in how we can use these different variables in order to solve for some of these issues here and to figure out what's the right dose for my patient, what's their volume distribution. All that's important clinically to be able to determine. So let's say, for instance, we have a new drug we have to call sarcastanol. It's used to treat excessive sarcasm, and it's a weak acid. It's got a pKa of 5.4, bioavailability of 90%, and a VD of 0.2 liters per kilogram. Again, 0.2 is less than 1, so we know that that's going to have a relatively low volume distribution. And let's say we're going to go ahead and dose it at 500 milligrams every 6 hours. Okay. Well, after a 500 milligram dose, how much of it actually gets absorbed into the systemic circulation? We said it's only 90% bioavailable, which means that 90% is going to get through. So I know that roughly 450 milligrams of that's actually going to get through there. Well, what would happen though, for instance, though, if I went ahead and I, changed the pH of the gastric acids, right? What if I were to give someone an antacid like Tums, calcium carbonate, and actually increase the pH of the stomach? Well, one of the things you might consider happening is because the pKa is 5.4, by bumping up the pH, because it's a weak acid, I'm going to have a higher proportion of this drug in the unprotonated state. And since it's a weak acid, it's going to be more charged. So you may actually find that by giving an antacid, you lower the absorption of the drug. You actually decrease the bioavailability, maybe from 90% down to like 80, for instance. So again, you got to think about these drug interactions and how the changes in pH can affect the absorption somewhat significantly, right? Now, let's say we were to have someone take a 500 milligram dose, let's say a 70 kilogram male. What would be the expected serum concentration I could get from them, right? If I know C0 equals dose over VD, I know the dose that I'm giving based on the 90% bioavailability. I'm going to try to draw in here. Don't laugh at me too much because I'm going to be trying to draw with my right hand with a mouse. Which looks better than I thought it would. 450 milligrams divided by that VD, right? So what's the VD? We're going to see VD is 0.2 liters per kilogram. So based off of that 0.2 liters per kilogram, I got a 70 kilogram male. That should be 35 liters, right? And if my math is incorrect, you guys can go ahead and stop me there. So 35 liters, and this is milligrams. Here's where my handwriting really gets poor. And so you're going to see, okay, well, what effect with serum concentration does VD have, right? I'm going to calculate that. So 450 divided by 35. If anyone puts that in the chat, I'm going to use my phone to do this. But don't have it in front of me. Right, so it's going to be 12 point, let's say 12.9, right? Where'd my mouse go? I lost my pen. There we go. So roughly 12.9 milligrams per liter there, right? But we can see like what effect on the serum concentration would VD have here. So if I were to look at this level, you know, we have 120 milligrams of propranolol to someone, we got a level of like 0.14. Here I gave 500 milligrams, I got a level of 12.9. That's much higher. So why is that? Well, it's because all that drug's concentrated into the actual systemic circulation because it's more, has a lower volume of distribution, right? So lower volume distribution, so we more staying in the bloodstream there, right? So the next thing I want to do, use the rest of my time here, is look at some basic dosing conversions and calculations. This is something new that I'm adding to the course that I've not done before, but I think is important. I think a lot of people, I assume, have these skills, but if not, I'd like to catch everyone back up. So there will be a dosing calculation quiz in Canvas. You can take it as many times as you want. You can repeat it as many times, totally fine. But I want you to successfully complete that. It's going to be one of the grades you're going to have for the class here. But here's some basic conversions and things I want you to do. So your requirements for successful mathematical skills in medicine. Can you do basic algebra? If the answer is yes, then you should be good to go. If not, don't worry. We're going to work you up to that. Just you wait. So first off, we're dealing with the metric system here. Unfortunately, the U.S. is still a little backwards in some regards. But for medicine, though, we're going to stick with the metric system, right? You want to know your common prefixes here. So kilo usually means thousands of a unit. Deci is 0.1. Centa is 0.01. I'm not using this one quite so often, but certainly the milli and the micro we're going to be using here, right? So 0.001, I missed this one, but it'd be 0.0001 in those cases here. So we're talking about like microliters, or we're talking about milligrams, things like that, kilograms. You know, those are kind of the more common ones you're going to be running into. And so it's important because you want to be able to convert between different systems needed depending on what you're working with, right? So for instance, here with weight, you can see here a kilogram is 1,000 grams. That makes pretty good sense here. Gram being sort of the baseline that we're going to be using for most things. Note that milligram is going to be 1/1000th of a gram. Okay, so it takes 1,000 milligrams to be 1 gram. Okay, and a lot of this seems like super simple, basic. That's okay. I want to make sure everyone's on the same page here. But just to compare, like a microgram, that's 1/1,000,000th of a gram. I need 1,000,000 micrograms to even equal 1 gram. I would need 1,000 micrograms to be able to get up to 1 milligram. And so that's important because we're kind of comparing things like, you know, morphine to fentanyl, 5 milligrams of morphine to like, you know, 50 micrograms of fentanyl. You can get a good sense for just how vast of a difference in terms of actual weight that is between one drug to the other. Some common conversions I do, though, on a daily basis when I'm working, are going to be things like, okay, well, I have a 1,500 gram premature infant, but my dosing is in milligrams per kilogram. Well, I should be able to convert that over. I know that having a 1500 gram, I know that I need 1,000 grams to become a kilogram, right? So go ahead and convert that over to 1.5 kilograms. Okay, and you'll get a feel for this. You'll be able to do this in your head, no problem, the more you work with it. Or what if I wanted to convert a dose of clonidine, which is an antihypertensive? It comes as a dose of 0.3 milligrams. Well, how many micrograms is that? Well, I just know that, going from a milligram to a microgram, I'm moving the decimal place over 1, 2, 3 spots, right? So generally when you're moving up these from these different units here, it's usually moving the decimal place to the left or right 3 spots. I know that 3.3 milligrams of clonidine is 300 micrograms. Or let's say I have someone who has neuropathic pain, they're on gabapentin. I take 3,600 milligrams a day of that. Getting from milligrams to grams, I'm just going to move the decimal place over 1, 2, 3, and now I know they're taking 3.6 grams in a day. So simple conversions, but common ones that I use pretty frequently in medicine here. This is really important too, especially when you're dealing with pediatrics. 1 kilogram is equal to 2.2 pounds. Okay, this is a common one you want to keep in your head for sure. And 1 pound is 16 ounces. Now, why would I ever do this? Well, for one, most patients don't know their weight in kilograms. They know their weight in pounds, right? Especially if they're coming from the U.S. This is also important too because frequently you'll find babies are weighed in pounds and ounces, which is not as easy to convert over to kilograms as you might like to see. But let's say, for instance, we have a 164-pound person. If I just take this and divide by 2.2, right, I get that they are 74.5 kilograms. This is so critical to do this conversion because if you don't and you dose a patient in, say, milligrams per kilogram off their pound weight, you're going to end up having way too much drug, right? You're going to give them 2.2 times the amount of drug they should actually get. Or let's say we have someone who has their weight in kilograms. We want to convert that over. In this case here, 115 kilograms times 2.2 will equal out 253 pounds, right? Or let's say we have a 6-pound, 4-ounce infant. Like, how do you convert that over? Well, by using the 4 ounces, and I know that 16 ounces is 1 pound, I can divide 4 by 16 and figure out that's 0.25 pounds. So I can say, okay, 6 pounds, 0.25 pounds, put that together. I can then take the 6.25 and then divide that by 2.2 and then get my new kilogram weight. I do this frequently, especially with like kids that are admitted to the NICU or things like that. So again, it's super critical you do this conversion. We do this a lot too, especially like in the ER. If you had a kid who came in coding and the parents only knew their weight in pounds, and especially if it was like an infant and they're like, I don't know, there's 6 pounds, 4 ounces. You got to be able to do that conversion pretty quick to get the dose of epinephrine for them correct. Otherwise, you're going to give them way too much, right? Potentially, harm that patient. How about for length? This one comes up less commonly in drugs specifically, but it's good to at least mention it here. Obviously, meter is going to be our base unit. Centimeter is going to be 1/100th of a meter. Millimeter being 1/1000th. This is good to note too. 1 centimeter is equal to 10 millimeters. Based off that conversion. And then when you're converting from inches to centimeters, which may be handy if you have someone who's reporting their height in inches, to be able to convert that over is really important because of things like when you're trying to figure out their body surface area or other type of calculations. This is good to know because most patients will know what their height is in feet and inches, but they may not be able to convert that over. So roughly 2.54 centimeters per inch. So for instance, if I had someone who's 5'11", well, I know that there's 12 inches in a foot, so 12 times 5, so that's 60 plus 11 inches, so 71 inches. And I can just convert that over. So it's taking that 71 times 2.54, and then boom, I know they're 180 centimeters, right? Or let's say it's someone who had a 3 centimeter laceration, right? So if you're working in the ER and you're sewing someone up, they say, I have a 3 centimeter laceration you're dealing with. You can then just divide that by 2.54 and you figure out, okay, it's 1.2 inches roughly. How about volume? This one we do a lot with medications, specifically with like liquid medications, IVs, oral liquids, things like that. Here, liter is going to be our base unit. So most things are going to be usually a subdivision of that. You're usually not dealing with like a kiloliter or something like that. But a milliliter is again 1/1000th of a liter. I need 1,000 milliliters to make 1 liter. Also, roughly 1 milliliter is just 1 cubic centimeter. So if you ever hear like give 30 cc's of that drug, that's what they're referring to, is 30 mLs. Also, 30 mLs is going to be considered 1 ounce. So if you hear like 4 ounces of fluid, 4 times 30 is 120 mLs, right? It's a good, easy conversion to do. And then 1 cup is roughly 8 ounces. Because again, patients will be giving you certain units, and you want to be able to do that conversion for yourself. So 1 cup is 8 ounces, 8 times 30. So again, 240 mLs is roughly 1 cup. Okay. And again, we have some stuff in the notes section you can look at too, especially when the calculations come up, and that'll help you out. 1 teaspoon, this is really handy because most patients will say, oh, I took a teaspoon of this medication, or I gave my child a tablespoon. We don't like to dose based off of these units anymore because most of the spoons you have in your house, if you got it from IKEA or Walmart or wherever you get it from, may be very different in terms of volumes. But when we say teaspoon, we're referring to 5 mLs. We say tablespoon, we mean 15 mLs. So 2 tablespoons is equal to 1 ounce. Okay, so you can start to see how you can interconvert these pretty easily once you get a feel for it. So a common volume conversion, so for instance, a half a liter, 0.5 liters, that's just 500 mLs, right? If I have 6 ounces of fluid, I know there's 30 mLs per ounce, that's 180 mLs, right? Simple multiplication there. So we got 4 teaspoons, right? I know there's 5 mLs in a teaspoon, so 5 times 4, get 20 mLs. Or if I had 60 mLs, how many tablespoons will that be? Well, there's 15 tablespoons per 15 mLs per tablespoon. So I take 60 divided by 15, and then I got my 4 tablespoons, right? So again, sometimes you may either get information from patients that are in imperial units. Sometimes you may be trying to convert things from metric back to imperial for your patients, depending on how they best know this stuff or how they best communicate, right? So drugs and concentrations, you're going to find that when we have drugs, they are frequently communicated as concentrations. So for instance, amoxicillin, 400 milligrams per 5 ml oral suspension, acetaminophen, right? Here's dopamine, 1600 mics per ml. So it's good to know the concentration here, because once you have a volume, you can then find out how much drug is actually in that volume. Here's some IV fluids, like 0.9% sodium chloride and 5% dextrose, so 20 MEQs per liter of KCl. Well, that's just D5NS with 20 of KCl, right? That's kind of a shorthand for how you might hear that being referred to. So in terms of like easy dosing calculations, so let's say you have an adult patient who is in pain and requires ibuprofen 600 milligrams. If you have 200 milligram tablets, how many tablets should that patient get? Again, this is kind of the simple stuff. We start at the simplest, and then I want to kind of make it more complicated as we go forward. So basically what we're going to do is take our desired dose and then multiply that by the available dose, and that way we'll get the number of tablets we have to use. Remember, you always want to keep your units straight. That's one of the most important things I can tell you now, is you want to keep your units straight and cancel things out when you can. So for instance here, looking at the 600 milligrams times 1 tablet per 200 milligrams. So if I can cancel out here, I basically got 600 divided by 200, and that equals out to be 3 tablets. Okay, so by making sure you keep your units straight and canceling out things when you can, this will keep things cleaner when you're trying to get these more complicated questions figured out, right? Let's say we have, let's see here how I organize this. I put the answer too early, but anyway, let's go to this one. Let's say we have a 20 kilogram child and they're diagnosed with influenza A, and then you prescribe them Tamiflu, 6 milligrams per ml oral suspension, 45 milligrams twice daily. How many mLs do they require per dose? Okay, so now you can see it's a little bit more complicated. So basically what we're going to do is take our dose desired, multiply that by the available concentration, and then that's the dose to administer, right? So what I know already is that, and again, I don't even need the patient's weight here. I already know the dose I'm getting, so 45 milligrams twice daily, right? So what I can do is take that 45 milligrams, that's my desired dose. And again, I wish I had a pen to do this with. This is so difficult. Multiply this by the available concentration, right? So I know it's going to be 6 milligrams. Actually, I should do, let me cancel this out. Let me see. I should probably screaming at me. It's like, this is so easy, but okay. Trying to do this to make sure everyone's on the same page here, though. Okay, so anyway, so at 45 milligrams, well, I know that in 1 ml, there is 6 milligrams, right? You guys are probably going to think I'm a literate after all this. So what does that equal out to be? Well, okay, I'll take that 45. The milligrams are going to cancel out here, right? And so I do that 45 divided by 6, which what do I get there? You guys are hopefully doing this with me at home. And I get 7.5 mLs.
So basically that means that patient is going to get 7.5 mLs twice daily. That's going to give them the 45 milligrams they require per dose. And so then you can then figure out how much to administer for whole prescription based off of how long they're going to get it for, how many doses they're getting per day, etc. Right? And I think I did put all the information down here in the down in the notes section. So if you want to check that out, yeah, you can see that you can double check my math there and get that information. Let's say we wanted to do something a little bit more complicated. Let's say we have a 25 kilogram child. I'm just going to keep the information down there so I can look at it without calculating all that out, because that writing is getting kind of obnoxious. Well, let's say we have a 25 kilo child and they're prescribed amoxicillin 80 milligrams per ml, oral suspension, 45 milligrams per kilogram twice daily. How many ml should the patient receive per dose? Well, what's the desired dose? Well, first off, you have to figure that out. And so in this case here, we know that they're getting 45 milligrams per kilogram twice daily. I know they weigh 25 kilograms. So I can do, if you look down here, 25 times 45 mg per kilo. I know that in total they should get 1125. So their dose, per dose amount they're going to get is 1125. 1 gram, 1.125 grams, right? So then once I have that, then I need to figure out, okay, well, what am I going to do with that information? So I know that I need to get 25 milligrams, right? But how do I figure out how much volume do they need to get there, right? Well, basically I can multiply that out. That's my desired dose. I'm going to say, well, 1 ml over 80 milligrams. And then that's going to then equal out to whatever it is. I'm going to have to sit there and calculate it. So it ends up turning into 14 mLs. So 1125 divided by 80, and then you end up getting that 14 mLs. Notice here that the milligrams cancel out, and you're left with mLs over. And that's what you want to tell the patient. You don't want to say to a patient, hey, you need to take 1125 milligrams of amoxicillin. You want to tell them take 14 mLs per dose, because that's what the patients are going to be able to measure up and actually give, or the parents can give to that particular patient, right? So that's typically how we do that. Let's say we have something else here. Let's say we want to get even more complicated. I think this is probably like the last one we have here. Let's say we have a 64 kilogram patient and they're to receive 10 mics per kilo per minute of dopamine, 1.6 milligrams per ml intravenous solution. This is a drug we would give to try to increase someone's blood pressure or heart rate in order to make sure they're perfusing very well. How many mLs per hour will this patient require? Okay, so it sounds pretty complicated right there on the face of it. So how do we figure that out, right? So I think I might just type this in, actually. That might be a little bit easier. So what's the dose required for this patient, right? So, okay, well, I know that if I have a 64 kilogram patient and they're getting 10 mics per kilo per minute, so I can already multiply that out. So I can take 64 times that 10, and so I know they're going to be getting 640. That's going to end up being, the kilograms are canceled out now, right? So I know they're getting mcgs per minute, right? Okay, that's all well and good. Well, how do I figure out what to do from there? Okay, what's the available concentration I have for this? Well, I said 1.6 milligrams per ml, but I'm dosing it here in micrograms. So I know I can go ahead and convert this over from milligrams to micrograms. I can just kind of move this over 3 spots. I can go to the right to 3. So I know this is going to be 1600 micrograms per ml, right? Okay, so I got that. So now the question is like, what's the volume per minute that they're actually going to be getting in that case there? Okay, so what can I do to figure that one out? So I have this, I know they're getting 640 micrograms per minute. I know they're getting basically 1600 micrograms per ml here. So what do I need to cancel out? Well, basically if I can go ahead and, how do I do it down here? Yeah, so if I do ahead and do that 640 micrograms per minute, and multiply that by, because I want to cancel some stuff out, I have 1 ml over 1600 micrograms. The micrograms now cancel out, and what I end up getting is 0.4 mLs per minute. I could then multiply that by 60 and actually end up getting what their total rate per hour would end up being. So I can then take 0.4 times it by 60 minutes in an hour. The minutes then cancel out, and that would then equal out to be 24 mLs an hour. Right? And again, this is kind of the most complicated it's ever going to get, kind of these multiple step sort of thing there. So that 24 mLs an hour would actually get down there. So the nurse, when they ask you, okay, well, that's great, they're getting 10 mics per kilo per minute, but how do I figure out how much volume they're going to be getting? Because that's what the nurse has to set potentially. You'd have to be able to figure out to tell them 24 mLs per hour. Okay. So again, it's complicated, but as long as you can go step by step and keep your units straight, you're going to be okay, right? So always follow the units. Make sure you're canceling out those units where it's appropriate. And make sure you're looking to see what specifically am I looking for. Am I looking for milligrams per day? Am I looking for mLs per hour? All of that, right? Make sure to convert everything back to metric. So if you get pounds, if you get ounces, convert it back to kilograms and mLs. That's always going to be the easiest thing. And again, when in doubt, bribe your local pharmacist. We tend to respond pretty well to chocolate, monetary remuneration. All that's going to be totally fine. Okay. Just kidding. But again, that's as complicated as it gets. So if it seemed like a lot, don't worry, work through it. Those math problems and the quiz will help you out with that process there. Okay. So we'll see how you do on that. Make sure you can do it over and over again. It's no problem. You'll be able to see which ones you got wrong and be able to go back through and make sure you get the optimal grade for that. So that being said, okay, so David asked, should we be prepared to do the more complex ones on the test? If so, we'll be able to have scratch paper. I'm not going to have you do, that's why I'm putting the quiz in, right? That's why I'm doing that quiz as part of your grade. So you don't have to do all those complicated ones on the test. I think we don't really have time to do really complicated stuff like that. When you're expected to do, minute and a half per question or so. So no, for this test, I'm probably not going to have too much math. I'll have to double check it, but if there is, I'll make sure you have availability of a calculator at the very least. And I'll talk to Dr. Murray about any scratch paper issues there. But yeah, I really want to keep this to the quiz to make sure that you guys were getting some good practice and are not going to run into too many issues there. So the other thing I wanted to do was go over the assignments real quick, if you don't mind me taking a few extra minutes here. I could operate my computer effectively. All right, so looking at the assignment, so there's going to be 2 that are due on July 24th. Hopefully you guys have looked at some of these already. I'm going to increase the size here so you can look at it a little easier. There's the drug information assignment that you're going to have. And basically you can see what your assignment already is for the drug. So I randomize this. And so you can see here what drug everyone got. There shouldn't be any duplicates or anything. So go ahead and go through that. Make sure you all have your drug listed there. And what I want you to do is actually go and find a drug reference, whether it be, I know you guys have access to UpToDate in your library. If you look up a drug in UpToDate, it will take you to a database called LexiComp. And I prefer that one. That's kind of my go-to one for the most part. And basically what you're going to do is taking your drug, go ahead and answer these questions here. And most of them you should be able to at least figure out based off what we've talked about here during these 4 weeks so far, or 4 times we've met. And again, if you have any issues, let me know. If you use a reference, and you should be using a reference because you don't have this information already, make sure you document that in AMA style, and I put a link there so you can determine how to do that. Okay, so that'll be one assignment to do in 2 weeks. The other one, as I mentioned, is going to be that quiz that I talked about. And so again, basically, I think I can just preview and show you what some of this will look like. You'll put in your answer. I already put in here, round to the nearest 10th of a kilogram. You'll be able to see which ones you got incorrect, and go back through, and you can do this as many times as you like to get the best grade you can. So if everyone wants to get 100 on it, they have that ability to do so. So that's not too big an issue there. Next week, I'll talk about the prescription assignment. That's when we'll get into talking about that a little bit more. So don't worry about that one. That's due on the 31st, I think. So have a whole other week for that one. Okay, so I only went over by a few minutes. Does anyone have any questions that I can answer? I already talked about these. There's a lot at the end there, but I think once you get the math down and get some practice with that, I just want to make sure everyone. I can't tell you how many times I had students in the past who come up and they just, didn't know how to do those simple conversions. So I take for granted, I think, that everyone just kind of knows how to do that when that's probably not the case. I want to make sure I at least got everyone the opportunity to learn that. And now you have no excuse for not knowing it, because I'll say, yep, I definitely taught you that. So no questions from you guys. Everyone's brains are probably smoking out right now. Steam. It's brains are working so hard. Okay, well, if not, you guys are free to go. That's it for me. None here. Perfect. Oh yeah, it'll be the test will be next week. It'll be similar to the first one. It'll just be covering the sections 3 and 4 of that. The math stuff will not be on there. That was just kind of a value add. That's something I added in this time around. So, but yeah, if nothing else, I will see you all next week. I'll probably we'll go ahead and just start at 9 again, like we did last time, and that worked out just fine. Cool. Well, thanks for joining me, and I will see you all next time.